are involved, they all need to understand what is happening so that everybody is on the same page and everybody is doing what they're supposed to do. School interventions have to play a role, and of course, medications. So our plan for ADHD really comes from this MTA study. It was a multimodal treatment of ADHD study. It was the largest one. It was multi-site designed. It took about 16 years of data. Started in, I think the first one published was in the 1990s, and they continued until recently 2017 that they stopped. And they looked at primary schoolers, ages ranging from 7 to about 10. And they decided that some would take only medication alone, some would do only behavior treatments or behavior therapy, and then some would do both behavior therapy and medication. And then some just went to the routine care. They weren't taking anything. And what they found out was that the kids who had the combined therapy did far better than all the other groups. And the second best were those who were having medication. Then the third was the behavior treatment. So let's talk a little bit about ADHD medications. So stimulants are usually the first line. So the stimulants increase the dopamine, norepinephrine at the synapses. You remember I talked about 3 neurotransmitters, dopamine, serotonin, and norepinephrine. The stimulants that we have available now for treating ADHD, they usually will increase these neurotransmitters so that there's more of it, because there's not enough in these synapses. And that is why the executive function and all the features of ADHD are coming about. So the stimulants are supposed to do that. And parents will always ask me, this child is on the go all the time and you want to stimulate him more. And the reason is that we're actually trying to whip up the child's executive functions, or their chief executive officer who has, gone on leave and is on a vacation. And that is why they are doing what they're doing. So that's what the stimulants do. There are various types. The main type, methylphenidate, and the amphetamines. Now, we also have non-stimulants because, yes, the stimulants may be contraindicated in some of the kids, or they may have so many side effects. And so we have a group called the non-stimulants, which is atomoxetine, clonidine, and amitriptyline. So this slide is a little crowded, but it just shows us the different stimulants and medications that are available. So these are the common ones. We can have short-acting, intermediate acting, long-acting. In Ghana now, we have Ritalin, which is a methylphenidate, which is short-acting. And then we have Concerta, which is also a long-acting methylphenidate. Sometimes we get our hands on Ritalin long-acting, which is an intermediate. And sometimes, I think AdPharma in a few places can get you some of the dextroamphetamines. So the first line is stimulants. And sometimes if one stimulant is not working, we sometimes go to a different type of stimulants just to see if it will work. But sometimes you cannot give stimulants and you have to go for the non-stimulants like Intuitive, which is guanfacine. It's an alpha agonist, and then clonidine or atomoxetine. The side effects of stimulants. So the major ones are reduction in appetite. I had a client one who was doing so well on a stimulant, but he just would lose weight. He would lose all his appetite. We did so many things, and he just kept losing weight. And I mean, for growing children, you cannot afford for them to be getting malnourished on stimulants. So sometimes we have to take them off if the appetite is so down. But most of the time, the appetite is just transient. The loss of appetite is transient, and they get better. We advise that you should, if they have that initially, then give them a big meal with the first dose and try and do that. If the stimulants can also affect sleep, they can cause headaches, nausea, stomach aches. they can have rebound effects. So especially the short acting ones, if you gave it to them and it was like Ritalin worked for 4 to 6 hours, what happens is that they are very good in school, and then the effects wane off. And by the time they get home, they have a rebound effect of all the features, and it's as if nothing is happening. That can happen sometimes. In the first year, it was shown to give a bit of delay height in boys, and sometimes they can unearth tics in some of the kids. And for the kids who have emotional dysregulation, they're really, emotionally in tune with their faculties, they can get moodiness and irritability. So let's go to behavior management. So for behavior management, the things basically we're trying to do is to help to be an external prefrontal cortex, external chief executive officer for the child. So helping in planning, in organization. So using of timers, creating charts, establishing routines, using planners, setting alarms, etc. So behavior management is really helpful in the preschoolers, because some of the preschoolers, the very early ones, like they're coming in, if they came in at 4 years, stimulants are not really first line for the preschoolers. So you may start with behavior management. And remember that we said the diagnosis is that the symptoms are actually impairing function. So what is the function of a 3-year-old or a 4-year-old? They are supposed to play and cause havoc. So you wouldn't want to then go and start stimulants for them. So usually we use behavior management as first line treatment for the preschoolers. You want to provide structure, reinforcers, so that desired behaviors are repeated. And then, of course, you want to give consequences for maladaptive behaviors. The hope is that as you're adding behavior management to your treatments or to your medication, this child will sort of internalize these behaviors that you are teaching them, so that when they are off medication, they would have learned how to, to deal with their challenges. We also would start with behavior management for the parents who are really anxious about starting medication, whilst you give them time to make up their mind. It would usually include both parents, school, and everybody who is in the child's life. So child management skills include positive reinforcements, as I said. You catch them when they are being good. So when they are doing something good, you want to encourage them to continue to be good. And if you give them rewards for being good, they remember. Then, of course, if they are being naughty, you give them consequences for that. Training them in problem-solving skills, because remember that they have challenges in their social skills. So social skills in kids with ADHD, they do not know personal space. They may be into your face, or they may be so near you, or they may be, poking into your things when nobody has asked them, jutting into conversations. You need to teach them all these things. That it's not done this way. You need to wait your turn, all these things. And that can be done through cognitive behavior therapy to help them to self-monitor themselves, to remember what they are supposed to do. Sometimes we teach them to give themselves verbal instructions. So you teach them things to say, that it is important to wait, breathe in and out, 1, 2, 3 before I do it. I think about something, I need to wait a bit before I do it. All these things usually will be done by the psychologist. So behavioral strategies that you can also use in behavior therapy: short, concise instructions. Remember that some of these kids have listening comprehension issues. So when you start talking plenty, by the second minute, they've forgotten everything that you are saying. So if you're giving instructions, instead of giving 4, give it 1 at a time, break it down. If they are doing a project, teachers need to help them to break the project down into steps. They finish A, they go on to B. If you leave it alone to them, remember, they cannot plan, they are not organizing, no sense of time is moving, duration. And by the time they are expected to pass in their work, they haven't been able to finish. Using of timers, and the older kids in high school, they have apps for them on their phones that they can help them with timing. reduction of distracting stimuli in the working area, movement breaks. That is really important. Movement breaks are really, really important. Lots of exercise. And so if they have to do something for 20 minutes, they could do it for 10 minutes, go and run around. If they can't run around, they can, the teacher can send them on errands. They are the ones who are supposed to share books and share pencils, so that they need to move, because these kids have to move. They just have to move. So you have to give them the opportunity to move. For progress.
Dr. Mabel, sorry,
yes.
Please, you have about 10 minutes now.
Okay, cause and prognosis. We have 50% who will progress into adulthood with all the things we are doing for them, who will still have ADHD in adulthood. Hyperactivity tends to reduce. So you won't see an adult with ADHD who is moving all over the place, but they have this internal experience of restlessness. They seem to be always wanting to do something new. They do so many projects, they don't finish, they continue to the next one. And inattention, distractibility, and disorganization tend to persist into adulthood. So evaluation, management, we've talked about evaluation, getting the diagnosis. You have to educate the family, because a lot of the kids will come and they have been beaten, they have been labeled as naughty children. All sorts of things have been done on them because they think they are lazy, they are just intentionally doing these things. When it's maybe it is ADHD, so you need to re-educate the family, turn their whole telling them around to from a different direction. Then, of course, you need to develop a comprehensive plan with for the family. Best, as I said, is behavior therapy and medication. And then we need to evaluate what we are doing, whether it's going well or not. Do we need to change medications? Do we need to change therapy? ADHD is real. It is not a parenting problem. It is real. It is a neurobiological thing. And if it is not detected early, the effects are really, really sad and bad on the children. So some of the effects of untreated ADHD, it impacts every aspect of their life. It can affect their school learning. It can affect their life. They can drop out of school. They are so emotionally immature. It gets them into trouble with authority, gets them into trouble with their peers. They can feel very isolated because everybody is tagging them as naughty. And that goes down to their self-esteem. They have low self-esteem. They're at risk of anxiety and depression. And they're also at risk of becoming addictive to other things. So they have the tendency for addiction because they are trying to self-medicate, nicotine and other things. And the biggest one is that underachievement. They are really brilliant children, but because of all these things, they may be failing in school. The family is also impacted. It's really stressful on family members, and it can even cause marital conflicts. And sometimes siblings may be resentful of the child with ADHD because it seems like every attention is on that child. Sometimes it strains relationships in their families. And especially for adolescents, they are increased, if they are not treated, they are at increased risk of substance abuse, as I said, road traffic accidents because they're not paying attention. If they are driving, it's even worse. STIs, because of impulsivity, they will go out with somebody and before you know it, they are doing something, they are not using protection, teenage pregnancy. All these things are effects of untreated ADHD. Effects on the adulthood, the same thing. It can affect responsibilities at home, relationships with family and friends, physical and mental health problems, and can even lead to criminal behavior. But ADHD is not all about challenges. They have some superpowers. They have strengths and characteristics that are really good. They can be hyper-focused. Remember I said if they love something, they can be so hyper-focused on it. They are resilient. Can you imagine going through life with all these things where your chief executive officer is not doing well? But the kids are so resilient. They are able to go through everything that life throws at them. They are creative, they are imaginative, they have so much curiosity, they are really funny. I had one in my office Saturday, he made me laugh and laugh and laugh. They are courageous, they are intuitive, they are spontaneous, and they have abundance of energy. And usually when you're doing behavior therapy, you want to hone on to these positive skills to help them so that they are confident about themselves. So I'm going to end with this poem. It's a poem by Andrea Chester. It says, take my hand and come with me. I want to teach you about ADHD. I need you to know I want to explain. I have a very different brain. Sights, sounds, and thoughts collide. What to do first, I can't decide. Please understand, I'm not to blame. I just can't process things the same. Take my hand and walk with me. Let me show you about ADHD. I try to behave. I want to be good, but I sometimes forget to do as I should. Walk with me and wear my shoes. You'll see it's not the way I choose. I do know what I'm supposed to do, but my brain is slow getting the message through. So to conclude, I want to say that it is really important that we diagnose accurately. Remember, there are differentials. You need to exclude, is this a child? Is this a gifted child? So do they need an accelerated program? Do they need an enrichment program? And maybe they don't have ADHD. Is this a child who has intellectual disability or a learning disability? Is this a child who is unsure something is happening at home and because of that, they are letting it out in school or at home? Are they being abused? Once it is diagnosed, it needs to be treated because the consequences of ADHD, as we have seen, without treatment can be devastating. So these are my references. Thank you very much, Amma.
Thank you very, very much, Dr. Marble. Thank you for such a detailed, insightful, and very engaging presentation. I'm sure we've all learned one or two things, and we have a lot of questions. So we'll move on to our panelist discussion / Q&A session. But before we do that, I'll briefly introduce our panelists to the house. So we have with us Dr. Evelyn Aboagye-Dumor. She's a mother and pediatrician with expertise in child development and behavioral health. She has over a decade experience managing children with ADHD and autism, and she's a strong advocate for child wellness and early interventions. She currently practices at Mercy in Missouri in the United States. In addition, we have with us an educationist by name of Madam Esther Awovi-Akafia, and she started her career as an attorney and an international development consultant, but saw education as her calling. So 5 years ago, she established Pioneers International Academy with a goal to develop young minds to make an impact in the world. And she believes every child has a capacity to make an impact and sees education as one of the tools to make this a reality. We also have with us Dr. Kwabena Pusi-Mensah. He is a psychiatrist and child and adolescent mental health professional and currently works at the Komfo-Anokye Teaching Hospital. Unfortunately, he had to drop off the call for a bit, but I'm hoping he's back on at this time. We're supposed to be joined by Prof. Ebenezer Baidu, one of our consultant pediatric neurologists at Kolibu, as well as Dr. Edem Tete, but they have prior engagements, and Prof actually had an emergency, so unfortunately he's not with us today. But we have the other panelists, so I'll hand over to my colleague Christina Trimartin, who will handle the Q&A session. Thank you. Christy, kindly go ahead, please. Okay, so if anyone has any question, you can just put your hand up and then we'll call you and we'll unmute you and you can ask your question. So Dr. Marble, I'll start off with a question.
Okay, that's some hands up though. Okay.
Okay, all right. Okay, just saw that. Let me just unmute. Dr. Christina, please go ahead with your question.
Okay, good afternoon. Thank you. My question is a simple one. For those who are put on medication for ADHD, Is it a lifelong treatment, or after a period they can be taken off the medication? Thank you.
Okay. Should we take a couple, or I should answer as we go, Amma? In fact, let's.
I think we should take a couple more questions.
Okay. Evelyn will answer.
Dr. Osman? Right. Dr. Osman.
Can you hear me?
So, Dr. Osman, please go ahead.
Can I be heard?
Yes, please, you can be heard.
Okay, good. So my question is, my experience with ADHD.
Okay, we can't hear Dr. Osman. Okay, now we can hear you.
Dr. Mabel did allude to it. Combining the medication and behavioral therapy really is good. It has a better outcome. But getting them to do behavioral therapy is a challenge. Even in places like the US, it was always a challenge getting them to go and do behavioral therapy. So my question, how is it easily accessible here in our environment for those who have ADHD to do behavioral therapy? Thank you. But thank you, Dr. Mabel, for the wonderful presentation.
Good evening. Sorry, I think I was earlier on muted. I'm Dr. Tremate because of the problem we had. So I think we'll take 2 more questions and then Dr. Mabel can deal with the first 4 questions and then we continue. Thank you. So we have Gloria Mponsa. I think she has her hand up. So she can go ahead and ask her question, please.
Yes, thank you very much, Christina. And Dr. Mabel, thank you for that insightful presentation. My question is that if a child on medication develops severe, side effects such as hypertension or like extreme severe anorexia, do you stop the medication for a while and then reintroduce it, or you'd rather consider switching to something else, another medication? Thank you.
Thank you very much. Please, so we take the last person for this round of questions. I think the next hand I see is Selom Tagbo. Please, you can go ahead and ask your question. Hello, please, is Selom still on the line?
Yes. Hello, good evening.
Okay.
Can everyone hear me? So I wanted to ask, I joined in the middle of the presentation, but during the presentation, there was a childhood situation and adulthood situation. So I just wanted to know whether it can be passed on. Let's say you had that situation and you're an adult now and it can be passed on to your children. And if that's the situation, what do you do at this stage? Is it that you are going to have that therapy with your child? Okay.
Evelyn, are you there?
Okay, thank you so much for your questions.
Marlon, I can hear the questions.
Evelyn, Evelyn, do you want to start?
So, yeah, definitely. I will take a shot at this. So okay. I have 4 questions that were, I've kind of summarized to make it a little bit easier. So I'll paraphrase just to make sure that I can, I'm actually answering the question the way that is being asked and that we are on the same page. So thank you so much, first of all, for PSG and then the pediatric residents at the Department of Child Health for this opportunity. I'm a strong advocate for making sure that children have all the necessary tools that's going to make them successful. And ADHD is one condition that, regardless of where you practice as a physician, you probably will come into contact with it. So the first question was about lifelong medication, right? So if a child has ADHD and is put on medication, will they continue to take medication into adulthood? I think that there's a lot of research that talks about the role that medication plays. And Dr. Mabel did an excellent job just talking about the different types of medications and their roles. When you have a child who is in elementary school, their challenges are a little bit different from as the child grows, to even middle adolescence and then adolescence itself. And so the features of ADHD may look a little bit different in terms of how it presents, but the core dysfunctions are still there. And so sometimes what I see in practice, I'm going to talk about just practice. Sometimes what I see in practice is that I'll have children who parents may be on the same page once you have parents buy-in and willing to try medication. And then when they become adolescents, they don't want to, or they think that they are fine and they can handle it. And then when they become adults, the short version is that there are adults who need to take medication in order to function effectively, to be able to keep a job, to be able to, to be able to be successful partners, to be able to be, even to be able to be successful parents. So there are adults who do require to take medication. The difference is that as an adult, you have to understand the condition that you have, and you have to recognize the challenges that you have, and to be able to be on the same page with a physician to make that decision. So there's a recent article. I know there are there parents on this on the forum as well? There are parents. Okay, so yeah. There was a recent article that was just published in Pediatrics that talked about the stages that parents go through in terms of understanding and coming to that decision place that this is what is good for my child, or this is what I need to do. And I found just reading the article really important in terms of even when it comes to physician engagement with parents, right? So sometimes we know the condition, we understand the condition, but the parents may be on a different level or a different plane, and that can be an issue when it comes to that. So in terms of lifelong medication, yes, that can happen. In terms of behavior therapy, there was a question about how are people accessing behavior therapy in our environment. And the question was spot on. It is a challenge, even here, sometimes trying to get parents to do that. It is part of why parent-led interventions are so important. So when it comes to managing your child, our parents have to have a central role in it, because you are an expert on your child. And when you partner, physician-parent partnerships are very important in making sure that you are getting the best out of that therapy that is being recommended for your child. And then you have to remember that not every therapy in terms of details of it fits for your child, right? So as you are working with the behavior therapists that you have access to, you are trying to come up with the best one that will fit the needs of your child. Your child is very unique. And it's so, even with ADHD, there is a little bit of a spectrum of presentation. So it's not like they all look the same or they all do the same things. And so the therapies kind of focus on the different areas. So in terms of accessing therapy services, I think that parent-led interventions, once they are coached, makes a huge difference in that. And Marilyn, you can expand on that. In terms of side effects and medication, so in practice, when I have to put a child on medication, I always start off with the smallest dose possible. And the reason is that it allows room for adjustment, but it also allows you to be able to identify any difficulties that the child may be experiencing. And sometimes, depending on the severity of it, like Marilyn had said in her presentation, sometimes you may have to change groups of medication. Sometimes you even have to switch from a first-line therapy medication to a second-line therapy medication. Sometimes if a child doesn't tolerate one stimulant, they may be able to tolerate another group of stimulants, because you talked about two groups of stimulants, right? And then there's also non-stimulant therapies that comes in play as well. And so you want to look at that. Overall, I think that the core, the key thing that I want all of us to remember is that she talked about medication as part of the treatment. So medication is not the ultimate part of it. when we are looking at a child, you have to look at the wholeness, the whole person. You're treating the whole person. And so I always make sure that my parents understand the importance of making sure, you know, your child has to eat right. Your child has to have good sleep. Your child has to be physically active. She talked about that. You have to have strategies in place to help your child to have periods where they can rest and calm themselves, because you are talking about executive function deficits. And so that's also important. That behavior therapy and medication comes together to be able to make that child have a better response in terms of, you know, whatever core deficits they have from ADHD.
Excellent, thank you. Evelyn, just to add for our local session, for what the question that Dr. Osman asked, how available is behavior therapy? I mean, your guess is as good as mine, Dr. Osman. It's difficult to get. And so what I do is what Evelyn said, parents-mediated therapy. So for those who can buy, I usually ask them to get certain books. I love Russell Barkley's Taking Charge of ADHD. It's really simple. I offer it to them to go get and read, and then give them the principles and help them to understand what is happening. Those who can afford behavior therapy with psychologists, then we refer. And usually once you have the diagnosis, there's usually a report that tells the school a few principles of what they're supposed to be doing to help. It's not easy. It's not easy for every family to access behavior therapy. So the parents-mediated ones are the best. Then, of course, these things that we do, like these Zoom conferences, so that the parents are, you know, they get to know, they get to understand, then they start reading about it. Okay, thank you. Can we have our next batch of questions?
Okay, thank you, Dr. Marvel. So I think two more people have their hands raised. Mr. Frederick Adiboka, please, you can go ahead and ask your question.
Oh, sorry.
All right, thank you very much.
Sorry, there was one question we didn't answer, the heritability. The last question talked about heritability. So yes, we said 2/3 are highly heritable in the sense that it's genetics, and minimum of about 25%. If your child has been diagnosed with ADHD, at least there's a 25% chance that one of the parents has it, and probably more percent chance. So if you have, your child was diagnosed and you think you had the symptoms as an adult, then you want to get diagnosis so that you become better able to handle you yourself and your child. And I think she asked a last question, that what do you do? Yeah, so what you need to do is to find out. If you think that you have those symptoms, then find out. And we talked about the acquired aspects. So the only preventable part is the acquired ones, but the heritability you can't do anything about. I hope I answered your question. Sorry, I forgot that one.
Thank you, Dr. Marvel, for remembering the last one. I think it almost escaped us.
Yeah.
Mr. Frederick, please, you can go ahead and ask your question.
All right, thank you, PSG, for this lovely workshop. It's been very educative. So my contribution is sort of a question stroke suggestion. In our bid to diagnose and identify ADHD early, I don't know if the colleges of education have it as part of their curriculum for the teachers that are trained. If it isn't, is it possible for the PSG to partner the Ghana Education Services or relevant institutions such that workshops can be organized for teachers who handle children or early education, so that we can increase early detection and diagnosis? Thank you.
Thank you, Frederick. That's a great contribution.
Okay. Wow, we have a lot of hands up. Please, James, iPhone. Please, you can go ahead and ask your question. Hello. It looks like James has a connectivity problem, so we'll move to the next.
Hear me? I'm right here.
Okay.
Hello?
Yes, please. We can hear you now. Hello.
Okay.
Please, you can go ahead and ask your question.
Yes, thank you. What is the difference between ADHD and autism?
Okay.
Yeah, that's my
Thank
question.
you.
Difference between
People
ADHD
address
and okay, all right, thank you.
autism. Thank you very much. Please, Abina Tano, please, you can go ahead and ask your question.
Sorry, thank you very much. So this is also a contribution as well. I think that being a bit rehabilitation biased, I wanted to emphasize that, and it's been spoken about the role of exercise in managing ADHD. There's a lot of evidence that shows that for people or children with ADHD, if they're able to engage in about 20 to 30 minutes a day of aerobic exercise, such as running, swimming, skipping, ball sports, cycling, all these things increase their attention and improve their mood. But one thing I've realized also is the fact that because they are hyperactive, especially for those who are hyperactive, parents or teachers don't want to limit them because they are afraid that they might go and damage something or spoil something, or they might get hurt. And so they limit them in terms of the kind of activities they engage in. But I think that we need to encourage them. And we need to also be able to teach these teachers, especially those in school, teachers at school, to be able to handle these kids very well. Because again, as was mentioned, a lot of them label them as troublesome children and don't want to engage with them. And then also, could we engage, is it possible to engage school owners? Because I have cases where school owners actually told parents that because of the way your child is behaving, we can't allow the child in school again. And so you have to come for your child. And it's traumatizing for the parents who already have to deal with these hyperactive children. So please, maybe we could look at that as well. By exercise, I think we should encourage teachers and parents to get them to exercise a lot during the day. Thank you very much.
Thank you very much for your contribution. I've noted your question down. We have about 10 to 15 minutes to finish with the question time. So I think I'll call the next set of people. Let's kindly be quick with our questions and suggestions. I'll call Prof. Goka. Prof. Goka, please, you can unmute and ask your question. Thank you.
Thank you very much. And this program has been very good so far. My question is, since ADHD has many differential diagnoses or comorbidities, would you recommend that a doctor who is not, who doesn't have a background in neurodevelopment makes the diagnosis? How laborious is it to exclude all those others? Because it can be very easy to just decide that you think the child has ADHD and start him on medication when the child actually has something else, a different diagnosis. Thank you.
Thank you very much, Prof, for your question. I think we'll take a couple more questions so that we can lump them together. Please, 418966, if you could introduce yourself, kindly unmute and let's hear your question. There's a hand up with the ID 418966. Okay, please, I'll move to the next person. Joe Sasu, please unmute and ask your question.
All right. I'm Joseph Sasu. I'm an educationist. Okay, I've been teaching. Hello, can you hear me?
Yes, please, we can hear you.
Very well, very well. I've been teaching for quite a while, and I must confess that I've been meeting such people. And though it's sort of hard to deal with such kids with that situation. Okay, but teachers do well to, contain such I want to still call it a situation. But my worry is, should new couples, okay, who have not given birth, is there a way for them to be sure that they do not have these traits of which they are going to transfer to their kids? And therefore, if there are any suggestive medications or, something to suppress these things so that we don't end up, giving birth to such people. Okay, so I want to know if there are such therapy or medication as is done in maybe other other situations or illnesses where parents are carriers and therefore doctors might give something to suppress those things to prevent inheritance. Okay, that's my question. Thank you.
Thank you very much, Joe. Please, we'll take the last question on this round. Fia Owusu, please kindly unmute your line.
Good evening. Please, I'm Mary. Please, I want to ask if there is, it's like there is food that such children should avoid.
Of course.
Or is there any food that increase or worsen the ADHD?
Okay.
Thanks for your question. Dr. Mabel, please over to you.
Christina, is Dr. Kusi Mensah still here? Do you know?
Yes, please. I'm still here.
Aha. Hey.
Okay.
Please, which one do you want to answer?
I'm not. I'm not entirely sure which one you think would be most appropriate. So I'll defer to you. I mean, whichever one you answer, if anything you want me to add to, I'll be happy to share.
Okay. So Evelyn and Kusi, I'm going to take there are 4 questions here. I'll take the first one.
Actually, 6 questions.
Oh, really? Okay.
There's the education and partnerships.
Yeah.
In terms of that, and then there's the difference between ADHD and autism.
Yeah.
There's a question on the impact of physical activity. Yeah. And then there's a question on recommendations in terms of which doctors can diagnose this and how laborious the process is. There's something about prevention of inheritance and then foods to avoid.
Okay.
Or,
the first 2, I think, were just contributions about the education and then the exercise. So I'll take the ADHD and ASD difference. And then
I can take the diagnosis.
Take the rest, yes. Okay.
I'll take the diagnosis.
Okay. So yes, as I said initially that about 50% or thereabouts of children who have autism may also have ADHD. In the beginning, before DSM-5, we were not allowed to diagnose ASD, which is autism with ADHD, but now it's allowed, it's a comorbidity possible. But autism in itself has some features of ADHD. So I can agree that it may be very complex to diagnose, but the core symptoms of autism are different from the core symptoms of ADHD. So for autism, we are looking at communication, social interaction, repetitive behavior, restricted interest, sensory needs. So these are very core to autism. So to break that down, we are looking at how the child interacts with his peers, interacts with the adults he knows, interacts with other adults he doesn't know. We are looking at how he's using his non-verbal gestures. We are looking at his patterns of communication, his style of communication, everything. Then we are looking at how he interacts with his environment. We are looking at sensory things. We are looking at repetitive behavior. And there's usually some hyperactivity in a lot of these kids with autism, but the core symptoms are very different. In ADHD, as we have said, We are looking at inattention. We are looking at hyperactivity and impulsivity. So to the one who answered, I hope I've been able to explain that in autism it's a social communication disorder. I did say that in ADHD they have some social skills deficits, but it is not because they do not understand the social rules. It's because their chief executive officer is not allowing them to obey the rules as they should, but they do understand it. I hope that's okay. Evelyn and Kusi, you can take over.
Yeah, I think you've even partially answered the question regarding diagnosis. But yes, it's a difficult. I mean, it's not always easy to tease out the different diagnoses and different differentials. But at the end of the day, we always go back to the basics. In medicine, how are we able to tell things apart when we have medically difficult diagnosis? It goes back to history taking and examination. And it's the same thing when it comes to these types of disorders. The difficulty is that very often many clinicians may not have the time and the patience to go through the rigor of, Dr. Mabel went through 18 different criteria and all of that, and it can be quite laborious. But if you do a thorough history, and very often, especially if you do a thorough history with the family as well, you take a thorough history with the family background, you take the time to even have a chat with the teachers. I found that to be quite useful. I mean, in our busy consulting rooms, it may seem counterintuitive, but in my own practice, when I've had the mother or the whoever the caregiver is to call the teacher, spend just 10 minutes of the hour-long consultation talking to the teacher, it can be extremely informative. And that very often can be, an important piece of the puzzle that will help you decide whether am I dealing with a conduct disorder or oppositional defiant disorder, or really sincerely, ADHD. And then also, of course, talk to the child. Never forget to talk to the child. In fact, sometimes, depending on the age of the child is the first person that I'll talk to, of course, with parental permission, of course. You'll be impressed and surprised at how much information the child themselves can give you. If a child is acting up, and then you have a child, reportedly acting up, and then you have a chat with the child themselves, and they tell you, I mean, of course, after you've gotten them relaxed, you've, established that therapeutic relationship, won their trust and all of that, giving them a box of Calipo or some toffees, they will tell you that, sincerely, I don't mean to offend mommy. Or some of them will tell you, especially in the conduct disorder, that, yes, I don't like mommy, or I can't stand this person, and that would be the clue, because in conduct disorder, in oppositional defiant disorder, there's no remorse. Like Dr. Mabel hinted at, whereas in ADHD, it's not because they are intentionally trying to be stubborn or to be bad children or whatever, but sincerely, their executive, the executive part of their brain is not handling things very well. So I guess the long and short of what I'm trying to say is that with a thorough history and a very good background history, including the family history, talking to the teacher, getting the corroborating bits of evidence, very often you will be able to have a good sense. It's a dangerous thing when you are in the middle of a very busy clinic. You have just 10 minutes with a child, which is not your fault. This child is acting up, and we see it a lot. You see them hopping from table to table, and then immediately say, "Oh, ADHD, Ritalin." That is where you run into problems. I mean, you can have a tentative diagnosis, but before you start pumping them with with stimulants, you should have at least had a chance to at least talk to the child one-on-one once before you jump to that conclusion. The quick thing that I'll add is, regarding the data, I mean, it's a minor point. I actually did a follow-up study, which was a larger community-based one, and the rates were higher. So the 1.6 was a bit of an underestimation. And in the community, I got about almost 3%. It's still nowhere near the 7% that other people are reporting. But yes, I think that definitely there's quite a bit of prevalence in the community, and interestingly, like you mentioned, in my study, I actually found higher combined than anything else, yes, in the community as well. So it just may be that the inattentives, which happens more in the females, is not, they are not reporting a lot in the clinic. which would make sense. I mean, most people would not notice that a child is having difficulty paying attention, but you would immediately notice if they're jumping from table to table and they are hyperactive or they are all over the place. Yeah, so I think that would be my short answer.
Okay.
Yeah, rather long.
I'm going to take the question on which doctors can make the diagnosis, because I think that's important.
Yeah.
In the US, you have pediatricians, family medicine physicians, psychologists, neurologists, psychiatrists who can make the diagnosis. And when I say pediatricians, even including general pediatricians with expertise in developmental, behavioral, and then of course, neurodevelopmental pediatricians. I think that if you look at the resources that we have in Ghana, we have to start looking at other medical officers, pediatricians that are interested, other physicians that can be trained and be able to make that diagnosis. So currently, based on the human resource knowledge that you have, that may direct you one way or the other. I remember distinctly as a medical officer practicing in Ghana and having a parent come in with a child that the school had kicked out. It was a girl, and she had symptoms that looked like ADHD. And when I told the dad, I said, well, you probably need to take the child to Kolebu for the child to be checked. And the dad did not have the resources to be able to take that child. So that girl was kicked out of school because she had severe ADHD. She couldn't even stand still, so fidgety, that the dad was like, well, then I'm just gonna take her out of school. So if we had physicians who were in local communities that were trained and be able to make the diagnosis of ADHD, I think that it will help in improving access to care and then also making sure that they can be managed properly. So that brings up the whole concept of training and whether we need to look at our medical curriculum again and whether we need to have physicians that can be trained or physician assistants who can at least identify and refer and know where to refer the children for them to be trained. So that's maybe one way to look at it. I also think she brought up the question about field therapy. Sometimes when you have a child that you think has ADHD and you treat with medication and there's no improvement and you've been able to rule out other things, or you've been able to look at other conditions that may be contributing, maybe you need to go back again and re-examine, does this child really have ADHD or is there something else going on? There was a question about the prevalence of prevention of inheritance, I think.
Yeah.
Yes, so I think that we have to understand that when something is inherited, something can be passed on. At least when it comes to ADHD, the research does show us that there is that inheritable risk. It is hard as a parent to know what to or what not to, right? Which parent is going to pass on or not pass on. The most important thing here that I want us all to remember is that every child can learn. Everybody is a genius, but if we judge a fish by its ability to climb a tree, it will live its whole life believing that it is stupid, right? I saw that quotation somewhere and it made a lot of sense to me. Every child has abilities. We just need to figure out how we can help that child to achieve the things that they want to. There was a question about whether we need to avoid foods to avoid or things that may increase ADHD. Remember that with all the causes that Dr. Mabel talked about, she talked about the fact that there is no definite cause, but there are risk factors and associations, right? And so food in of itself does not cause ADHD, but we do know that there are certain types of foods that sometimes seems to make things more obvious, right? So if you have a child who has ADHD, there's a lot of talk about maybe limiting processed foods or making sure that that child is having enough foods that contain omega-3 fatty acids or certain types of vitamins and all of that. What we need to understand is that those things are not causality. They don't cause ADHD. They may help improve some of the symptoms because, of course, when you eat better, you feel better, you act better. So if you are giving your kids foods that are less processed, it's much better. And our foods in Ghana is probably the least processed when you look at our traditional foods, probably some of the least processed foods that we have. And so we have to have that at the back of our minds. In terms of physical activity, I just want to say this. two of the top world Olympic gymnasts, Olympic athletes. So if you look at Simone Biles is one of the all-time great Olympic gymnasts, and she has ADHD, right? So physical activity, improving physical activity, she found that being a gymnast was one of the things that helped her to kind of get away, be able to handle some of her hyperactivity. Doesn't mean she didn't still have challenges, but she was able to use that skill and develop that and become a top world athlete. It's the same with one Olympic swimmer called Michael Phelps. Her mother realized that he had ADHD so bad and he had a lot of hyperactivity, and he picked up swimming as a sport and was able to develop it to become one of the top athletes of all time. So in our part of the world, well, our children may not necessarily have access to swimming, or they may not have access to some of these things. There's so much physical activity things that they can do. Some of our cultural dances, there's a lot of jumping and dancing and, totality. It can provide a lot of physical activity for them. We grew up playing ampe, jumping all the time outside. We have to get back to getting our kids to go outside and play. It's so important.
Hello, Dr. Mabel.
Yes.
Yeah, I think from this particular set, there are two more questions about how the educational system is inculcating the training for ADHD, and also how we can engage school owners, especially those who are not willing to admit children with such difficulties.
Okay, I'm not sure about what is happening in the education background. I can't tell. Kusi, do you have any inclination? I do know,
people are complaining.
A couple of years ago, there was
people are complaining about it. Schools have kicked their kids out because of their hyper.
Please,
so Marilyn, I could actually come in here. This is Esther. So
okay.
I could,
yes.
Okay. Yes, so I could actually come in here. So yes. I work in the education sector with Pioneers International Academy. And when we established our school 5 years ago, what we immediately noticed was there was a high need for helping learners on with different skill sets, learners who did not behave like the other children we saw around. And for us, what we also noticed was that there were no resources available. So our first point of call as educators was to reach out to some of the special needs schools that were already in the country, New Horizon, another one in East Legon, and said, we don't have the expertise to deal with children with different skill set. What do you do? And they were kind enough for us to send some of our educators, our teachers, to go and understudy what they did. And then we subsequently enrolled some of them in courses online or research. Now, you asked whether the universities do have a program. I'm not aware of a program that focuses on learners with different learning difficulties, but I do know that University of Cape Coast, as part of its education curriculum, that's exposed their students in this area, and there are individuals who are now doing research. Now, for us as educators and as a school, when a learner comes to us, we first want the parents, if they are aware of the difficulties the learner faces, to be very transparent with us from the beginning. So sometimes a parent may approach you and say, I want to bring my learner here. And then you notice by finding out the history that the child has been already in 5 schools, but the child is only 8 years old. And when you ask the reason, they're like, oh, this school wasn't good, this school wasn't bad. Then after interaction with the learner, you notice that, oh, there's something that is different from this learner. For us, we are a school that is focused on developing the whole child. So then we go back to mother or father or grandpa and said, okay, we've noticed this. We want to work with you. And for us, we've been working with Dr. Marble and her team for the past 5 years. So with parent consent, we send the child and we have a diagnosis, we have an assessment, and we come back to parents and say, these are the recommendations from the specialist. Would you work with us on that? and then we do that. So from the parent perspective, it's time consuming, it's expensive. From the teacher's perspective or the school's perspective also, it needs that collaboration. So if you are parents in that space, what I will encourage you to do is first, just let your school know that this is the challenge you're facing at home. And if they say they're also facing a similar challenge, say, you know what, that's why they're in the school. I want you to help me to solve this and be equally committed. I have parents who will go and do research and said, we found out this, what do you think? And I said, okay, let's go and find out more. So be very committed to that process. And also, if you're an educator on this platform, I will encourage you to welcome all learners into your school. I know that it's very difficult to have a learner who may be jumping up and down. So decide what is your limit, but don't exclude everybody because they are not standing for 5 minutes. There are also activities that you can engage in. So as a parent, as a teacher, what are some of the things you do? We had one learner who was very hyperactive. And we noticed that when you engage them on hands-on activities, they could do well. So beading was something that learner had to do, even though he was in preschool. So beading, because the entire concentration is on beading, and then you reward the learner. So you've done beading for 3 minutes. You notice that you didn't get up. If you do it again, if you can sit in the class for 3 minutes, I will reward you with another beading. That helps. The other thing you can do is give them responsibilities, right? So think about your classroom helpers. You are the one who assists the teacher clean the classroom. You are the one who assists the teacher do A, B, and C. They need that. They need a way to emit that energy. So that helps. Somebody also talked about exercise. It does. I currently have a learner in my school. He loves Fridays. Fridays are sports day. And in the early years, I mean, when you see him, he's coming to school, he's already running to school. He's a learner who is hyperactive. He needs that. The other thing also is, think about milestones. So when you're working with your learner, incrementally increase your expectations. If the learner is doing 5 minutes today, let them know your expectation is that in the next 2 weeks, I expect you to get to 7 minutes attention before we go out. I expect you to get to 15 minutes. And then gradually check that. It works. One of our panelists said that everybody can learn, and it does work. People can learn. And if you're parents also, and you go and see a specialist and they say, you know what, you need to spend more, be willing to do what it takes to find that extra money to make it work. So maybe they may ask you to get an assistant teacher to work with your learner in the specific classroom so that they can engage. And this is the reason why. If a teacher has 12 learners in the classroom, they have certain things they have to cover. Now, one learner who needs to be getting out of the classroom every 7 minutes means that there wouldn't be enough time for the other learners to participate. So what it means is that the teacher will need an assistant. Unfortunately, a school cannot bear that cost. So that may be something that will be thrown at you. Just understand that. And also, if you don't have a support group and you're going through this, find support groups. There are parents who have learners with different difficulties on Facebook. Ask your friends. If you're not sure, reach out to some of the panelists. I know Dr. Marble will be able to find you, perhaps contact her as well, and say, look, I'm a parent with a child with these difficulties. I'm struggling by myself. Are there any other parents? And that support group will help you, because some of the things that you faced already, they've faced it. So basically, it's something that is with us. It is not a curse. It is not a disease that most of the time you have caused. It's our children. They thrive on love. They thrive on affection. And that love comes from the home. It comes from the school. It comes from the community. So let that be the foundation, and also be committed to see them succeed. And they would. You will see the milestones. So also measure the wins for yourself. Notice the little changes. I have a learner. Ordinarily, he should be speaking, but he doesn't speak that much. But he does 9th grade level math, right? and he reads at 7th grade level, right? You give him anything, he will read. You give him math, he will do, but he's not ready to speak. So what do? You work from their strength, right? Give him books as he's reading, interacts, and measure the successes and the milestones. So that's all I will add to the various things that have been said so far. Thank you.
Thank you very much. I think we've spent a lot of time, but 2 people have had their hands up. So I'll let them ask their question, and then I'll go into the chat. There are 2 more questions that need to be tackled so that we can round up. Thank you. So Dr. Yanieta Okai, please, you can ask your question.
Yes, I wanted to find out if there's any link with excessive screen time in early childhood and ADHD, so that we know, especially there's patients that we come into contact with, to caution them about a lot of screen time when their children are younger. So I just wanted to know if there's any link. Yeah, thank you.
Thank you, Dr. Yanieta. Please, David Whitman, Siame, you can ask your question. Snap, please.
Let me say a big thank you. I want to ask thank you very much for your presentation. I'm asking if you give students with this problem or this challenge more difficult questions, it will help to make them relax, as in make them reduce movement and concentrate. Thank you
for your question. Dr. Mabel went through the diagnosing.
I can't hear Christine now.
Yes, I think she's gone off. I also can't hear her. But I think we are running out of time.
Yeah.
So
someone still asked if
can we answer the last 2 questions?
So that we can take them.
Yeah, Evelyn, answer the last.
Yes, so that we can wrap up.
Yeah. So I think that for parents, first of all, the question about screen time and ADHD, there is no research that says that if you use more screen time, you are going to develop ADHD. However, we do know that if you have a child who has difficulties with executive function, if a child is just sitting down watching screen time 3-4 hours a day, that can become a problem in of itself. And so even though there's no research which says that excessive screen time leads to ADHD, there has to be some moderation in terms of how much time children spend on using screen time. So I know the American Academy of Pediatrics recommends about an hour of screen time maximum and no screen time for children below the age of 2 years, which if you think about it, traditionally, even in our social cultural setting in Ghana, children below the age of 2, we encourage them to interact, to play, to do all that, right? Preschoolers, elementary school kids, we want them to do that. We don't want them to stick watching something on screen. Children learn through interaction and through play. So we want to encourage that. There was a question about whether more difficult questions will increase concentration. What we have to remember that the deficits that she was talking about or dysfunction is not that these children cannot pay attention. Some children with ADHD have exceptional abilities in different areas. So giving them more difficult questions is not going to necessarily improve attention in a child who has maybe an associated learning difficulty or has an associated intellectual impairment or another comorbid condition. However, if you have a child who is bored in school, has exceptional abilities and is just doing things that they have already mastered, then those kids are going to be more likely looked at as, having difficulties. And so when you give them things that are questions that are a bit up to their ability, they tend to be able to sister. I remember my second child personally, when she was in kindergarten, her teacher had called and said, well, she was moving around and wasn't sitting still. And it ended up being that she needed more challenging questions, needed to do more things to keep her occupied, right? And so that was not ADHD at all. That was a child who was bored. And so you have to be able to figure these things out. I think the most important thing that I want to leave everybody is us understanding that when it comes to ADHD, it's parents or caregivers, teachers on the same page, physicians, all of us coming together and forming that partnership so that we'll be able to work towards unearthing the potentials that the children have, because these are kids that are extremely gifted sometimes. They have different sets of abilities and we have to be able to support them. This is also in a way a call to action, right? In terms of what PSG can do, collaborating with educational institutions, special needs, special education instructors, advocating in terms of policy change for our schools to be supported, because a child here in the US, for example, may have access to an individual educational plan or a 504 plan to make accommodations for some of the changes. We have to advocate for children in Ghana because there's so much potential that they have as well. And if they are given the support and the environment that they need, they'll be able to, to reach their full potential.
Okay, thank you very much, Dr. Mabel. Thank you to our panelists. I think time is fast spent to end here. And I would invite my colleague, Dr. Ekem, to take over from here. Thank you, everyone, for your questions. Thanks to our panelists, too. God bless you.
Thank you, Christina. We'll take the closing remarks by our chairperson, Dr. Osman. But before he does that, I'll just like to say the climax for our advocacy program is a donation to children with special needs at the Osu Children's Home, as well as a donation to the neurology clinic at Kolibu Teaching Hospital in the Child Health Department. So any donation in cash or kind is welcome. We'll leave our contact number in the chat box. Okay, Dr. Osman, can you kindly give us your closing remarks? Thank you.
All right, thank you, Dr. Ekem. I'm going to be very snappy because I know we've run out of time, but I'll start on a lighter note. I remember during residency, I had little knowledge of ADHD during my first year, and during one discussion about ADHD, the consultant who were having a discussion with asked whether, this was in the US, the consultant asked whether we in the third world, we diagnose and treat ADHD. And I quite remember the answer by one of our Indian colleagues. He said he believed we have it, but we're beating the head out of them. Oh. So, yes, it's true. I mean, over here, even though the condition is there, because we don't have the solution, we beat them, and that is the solution, sort of. But so this advocacy is really important. I believe that after this, we've all got educated and we'll be disciples of spreading the word about ADHD and for people to know that there is, it's a condition in the first place and there is treatment for it and the outcomes are really good. Personally, I have, in my previous practice, about 10% of my patients were ADHD patients and I see the difference. And it's really remarkable to see them respond to treatment. Somebody wants us to end. We'll end soon, but please be patient. All right, so I just want to comment on one thing that Mr. Frederick said, and I think Mr. Sasu also said something in that line, that teachers have to be involved. In the US, most of the time, the teachers who actually start the process, they tell them, the parents that we think your child has ADHD, and then they actually have the rating skill, they have the Vanderbilt and well in the US sometimes the teachers have a special rating skill. They will actually fill it and give it to the parents to bring it to the doctor. Then the doctor will do the parents' rating. Then the diagnosis starts from there. The evaluation starts from there. So we need to actually get to that stage of involving our teachers so that they can identify such children and refer them to the doctors to get evaluated and possibly treated, because when they are treated, the outcome is really good, and we don't have to let these children suffer all the years and losing their things, not paying attention, and their academic suffering. So I'm not going to talk too long. I want to thank everybody for joining. I see that a lot of people have been very steadfast and waited. We had over 300 participants at every time of this presentation. The initial glitch we had with the hacker really disrupted us, but we were able to persevere. So thank you all for joining. Thank you to PSG for partnering the residents at Quality Teaching Hospital to make this program a success. So thank you all and have a good evening. Over to you, Amma.
Thank you very much, Dr. Osman, for your kind words. We'll take the vote of thanks and then the closing prayer by Dr. Erikwa Forson. We've noted all the email addresses that have been dropped in the chat box. We'll try and get you the recording and the slides if possible. And then also, if there's any parent on here who still has questions, you can always contact us at the OPD at Kolebu Teaching Hospital or Dr. Mabel at Mission Pediatrics. Someone wanted to say something.
Yes, for the recordings, all those requests for the recordings, this presentation was streamed live on our YouTube channel, so you can rewatch it. You can log into Pediatric Society of Ghana on YouTube and rewatch the entire presentation. Thank you all so much, and please remember to subscribe to our channel.
Thank you very much. Okay, Dr. Forson, can you kindly give us the vote of thanks and then the closing prayer? Thank you.
Good evening. I believe we have all had a great afternoon with a lot of acquisition of knowledge, which will help our patients and our clients in a great deal. You agree with me that we couldn't have done this without our resource persons, Dr. Marilyn Mabel, and our panelists, Dr. Evelyn Dumont, Dr. Akusi Mensah, and Madam Esther Akafia, who have spent their precious time to educate and enlighten us on ADHD. To our sponsors, Mr. Michael Dakwa of Team 1000 Words and Mr. John Aja, we could not have done this without your help. We'd also like to acknowledge the Department of Child Health, Kolebu Teaching Hospital, and the Pediatric Society of Ghana for their support. To all those who have supported in cash and kind, we cannot thank you enough. And finally, to you all who tuned in, this would have been a futile exercise without you listening and contributing. Thank you all for joining and listening, and may God bless us all. Shall we pray? Heavenly Father, we thank you for a successful meeting despite the initial mishap. It's our prayer that we'll be able to use the knowledge acquired to impact the lives of all children, especially children with ADHD, and to change their lives for the better. Thank you for answered prayer in Jesus' name. Amen.
Amen. Amen. Thank you all so much for joining. Have a good evening.
Thank you. Bye.
Bye now.
Amen.
I think still ended.
Thank you. Bye.
Thank you. Bye.
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 Somebody's child.
That is same, right? It's a team of doctors. I don't know, somebody.